Welcome, everyone. I'm Dr. Jeannie Alter. I serve on the board of directors of the American School Health Association, and thank you for joining us for the second installment of a two-part webinar series exploring research on youth and adolescent obesity. These webinars are an exploration of the applications of research appearing in the March 2013 issue of the Journal of School Health. The American School Health Association is proud to partner with the United Health Foundation for this important discussion of a critical and complex issue facing our young people. As you can see on the next slide, we will cover a tremendous amount of ground today. Overall, we hope that you'll leave with a better understanding of the factors involved in childhood obesity and strategies to address this issue. And I also want to make note that this special issue of the journal will be available through our website to everyone, despite being a member. So please be sure to check that out on our website. A little about the American School Health Association. We are a multidisciplinary association of close to 1,000 people. We are the proud publishers of the Journal of School Health, a premier journal in the area of school and adolescent health. If you are a member of ASHA, you can elect to receive a hard copy or an electronic copy of the journal. And the price of membership is inexpensive, and for the price of admission, you receive the journal, a discounted registration to our annual conference, and free continuing education hours. So please consider joining, volunteering, and becoming a member of the ASHA community. We also hope that you'll join us October 9th through the 12th for our annual ASHA conference in Myrtle Beach, South Carolina. It will prove to be a wonderful conference, and we sure hope to see you there. For continuing education units today, we're asking $30 from non-members and offering continuing education at no cost to members. After the webinar, you will receive 1 hour of continuing education. And please take a look at the archived webinars available on our website. As I mentioned before, ASHA is thrilled to partner with the United Health Foundation to bring you this webinar series. And I'm pleased to introduce our facilitator, Dr. Anjali Jain, Managing Consultant with the Lewin Group, and also a contributor to this issue of the Journal of School Health. I'll pass it along to Dr. Jain so she can tell you a little bit more about herself and get us started. Dr. Jain.
Good afternoon, everyone. Thank you for joining. And we have a really great group of panelists, so we're going to make introductions really short so that we can get to the meat of the material. My name is Anjali Jain. I'm a pediatrician by practice and training, but I'm also a health services researcher. I've been working for about 15 years, I'd say, in the field of obesity research and policy. And I'm currently with the Lewin Group, which is a health and human services research organization that is part of the United Health Group family of companies. And I am pleased to be an author on one of the pieces that was discussed in the last webinar, which was a school-based initiative in 6 school districts in the southern U.S. That was also part of the United Health Foundation work, as well as they were integrally involved in how it was designed and carried out and continues. So that's all I'll say about me, but I was going to go ahead and introduce our first speaker. Again, all of our speakers have very long and esteemed histories and bios, but in an effort to get to their presentations, I'm going to be shortening them considerably. So first on our docket, we have Dr. Lusako Makayer. I hope I'm saying that correctly. She's currently an associate professor in the Department of Health and Kinesiology, as well as in the Department of Health Promotion and Community Health Sciences at Texas A&M Health Science Center. She's also the director of the Transdisciplinary Center for Health Equity Research and founder and director of the Child and Adolescent Health Research Lab. So she'll be doing her first presentation on her work as presented in the Journal of School Health. Dr. Lasaka? I mean, Dr. McIer, sorry.
Hello, this is Lasaka McIer. Can everybody hear me now?
Yes, thank you.
Yes. Great. Thank you so much for this opportunity. I will go through this pretty quickly, and again, thanks to Jeannie Alter for inviting me to do this and arranging it. My presentation today is about elementary school personnel's perceptions on childhood obesity, pervasiveness, and facilitating factors. Now, what I will plan to do today is to describe briefly the Student Wellness Assessment and Advocacy Project, which the acronym is SWAP. And in this study, or today's seminar, I would like to tell you a little bit about some of the school stakeholders' perceptions of factors and facilitators and barriers related to childhood overweight and obesity, and their roles and those of referent others in their children's sphere of influences. And hopefully by the conclusion of my section of the webinar, the participants will be able to identify key stakeholders who are in school settings and their roles specific to childhood overweight and obesity prevention research. I would hope that the participants may also be able to describe the research findings about stakeholders' perceptions on childhood obesity factors, including the range of perceptions from various types of stakeholders. And of course, articulate how these research findings relate to practice, as that's very important to me, particularly in school-based settings and community-based settings. So SWAP, our acronym, is an NIH-funded, or was an NIH-funded project as part of our P20 Center grant, of which it was comprised of 3 major research projects of R01 type. Our project, which was a 5-year study, was to address several factors, and the aims here are presented on your screen. Yes?
We cannot see your PowerPoint. Is it on your screen?
How about now?
Now we can.
Oh.
Even better. There you
go.
Okay. Thank you. Thank you. Sorry.
All right. That's okay. So let me, let's see if we can. Okay, so now we're on this slide. So today's presentation will focus on what we did during the initial phases of the project, which is assess the awareness and knowledge level about federal and state nutrition and physical activity policies or school wellness policies among study participants. We did both parents and school staff and teachers, but today I'm just going to focus on the school personnel. So why did we do the study? Well, as you all probably know, Congress had passed the Child Nutrition and WIC Reauthorization Act of 2004, which mandated all school districts to develop a wellness policy guideline which would be effective in 06-07 school years. And these policies were designed with 8 conceptual components to disintegrate behavioral risk factors. For example, amplifying health education, or eliminating low nutrient-dense food from school cafeterias, or increasing physical activity, and so forth. Now, prior research has demonstrated that students learn most health education information from their classroom teachers, and we know that. Now, similar studies reveal that teachers are good role models, too, for increasing fruit and vegetable consumption in children. So, we know, and everyone in ASHA knows, that teachers are vital to change student behaviors and in implementing and understanding the school wellness policy. Now, given the importance of teachers' roles in addressing the issue of student health within the school setting, we think it's important to clarify their own knowledge and awareness of these school policies that are actually affecting them. And so the purpose of this particular exploratory study was to ascertain just how much teachers and other school staff in 3 rural independent school districts in Southeast Texas know about school wellness policies. So what we did was we looked at school ISDs that were in rural Southeast Texas, and it was and it's unique in that it's rural and predominant minority. We have a sample of elementary school personnel, which included teachers, nurses, food service directors, and administrators, such as principals. And what we did was conducted semi-structured audio-recorded interviews. The questions were designed to assess the participants' awareness and knowledge of school wellness policies and their perceptions on policy improvement and implementations. So we actually wanted them to let us know what would be helpful and what would be a hindrance, roles and barriers. So we ended up with, of the 40, 30 were fourth grade teachers. We had 3 principals, 2 food service directors, and 5 nurses. About 65% white, 22% African American, and about 13% Hispanic. And surprise, surprise, about 85% female. And we used a Atlas TI to content analyze after the interviews were transcribed. So the fun part, we came up with 3 themes that emerged specific from this particular subpopulation. There were limited knowledge of school wellness policies found among teachers in this particular school. We had speculations about what the policy might be. And we also, interestingly and fortunately, had teacher-generated recommendations to improve wellness policy dissemination, which is what we were actually trying to get at. So here's what we know about the limited knowledge, or what we learned about the limited knowledge among the school teachers. We ascertained that the knowledge is sort of compartmentalized and lacks detail. So, for example, food staffs were aware of the food-related aspects of the school wellness policy, but very little knowledge or even awareness of the existence of the other parts. And PE teachers, for example, were aware of the physical activity aspects, but had very little knowledge of or even awareness of the school service parts, which is suggestive of sort of the discontinuity here in information that's going throughout the schools. What's critical to us, however, is the detailed knowledge of school wellness policy lacking among the teachers who are our front lines. They're the ones who are the ones conveying the most information and the most influence with the children at this particular phase. So it was a little bit alarming for us to find that out. Well, I have some quotes here from some of our teachers that I'd like to share with you, which sort of describes or illustrates what we mean by limited knowledge. Here's one teacher wrote or said, "I'm sure it's a state-mandated policy, but I'm not sure what it is." Or, "I am aware of some of the guidelines, but I don't know all of them. And I know they teach the teachers about different sorts of things for PE, and I don't know a lot about the details about it." So again, these are just excerpts of the interviews that highlight what we mean by limited knowledge and some vague awareness. Interestingly, the detailed knowledge of school wellness policy was evident among principals. So this principal excerpt shows that the level of detail. This particular person stated it involves nutrition, it involves the PE and education. We normally use it, talks about the different foods that are affecting the age, the different foods they can't eat. It talks about the different serving sizes in the cafeteria. And for PE, you know, how much exercise and community involvement and things like that. So this is just a small snippet of what this particular principal said. And it demonstrates really the comprehensive picture that it involves more than just PE or nutrition. It's a very comprehensive approach. Now, the teachers also are related to our finding too, tended to respond with questions to our questions. So there were some speculations in their responses in trying to figure out what it was as part of the process. They would answer or ask questions like, "Honestly, I don't know much, but I do know that students have to receive so many minutes and hours of activities throughout the week." Or they would ask, "Does it have to do with the cafeteria snacks, or maybe we just talk about, or what?" Again, highlighting that they are aware that it exists, but the detailed knowledge that is probably required to actually implement it in a useful way for our children is not occurring. The teachers, related to our third theme, came up with several recommendations. Now, in spite of the lack of awareness, they were willing to make suggestions on the development and implementation of wellness policies, and I think many of you would be very pleased to see how constructive many of these are. They gave us advice, for example, on who should be involved in the development and who should be collaborative in establishing the implementation of this. As an example, regarding who should be involved in the development, we received responses such as, I would say, teachers, parents, community members, and experts. That was a response from one teacher. Another teacher indicated, in this case, nutrition experts, because the parents, are obese stakeholders. Okay. Most respondents referred to the greater collective, which was terrific because they understood then that the importance of stakeholders beyond those of the school gates was important in making this successful. Now, when they were asked who should be collaborative to establish the effective wellness programs, their responses were of a wide variety of experts, as you can see from this excerpt here from one of the teachers' interviews. And another person indicated that a group of people together who have the knowledge, like doctors and physical activity teachers, to design and implement programs. So again, in this case, we were pleased to see that they acknowledged the limitations of their own areas of expertise and were willing to reach out. The interesting part for us was the role of parents and the paradox. And what we mean by that is, when we were interviewing these teachers, it was very clear that we were asking them in the role of teachers, but it almost came across as though they had forgotten or dismissed their dual roles for many of them as parents. And it was almost a we versus them. So one example is they wrote or said, I'm thinking the parents need to know what is healthy for their children to eat so that they can substitute the junk food, which presumes that parents are giving them junk food. And again, the other one refers back to the parents as obese or part of the problem. Still, this person tried to acknowledge that their buy-in of the parents are important, but nevertheless, it sort of indicates this we versus them mindset. So what do we know? We know that there's limited knowledge about school wellness policies among administrative school personnel. We know that the teachers recognize school wellness policies are mandated, but that they lack the specific knowledge that impacts implementation. And what this means is that our findings, however, are consistent with other studies, those which have examined the effectiveness of school wellness programs. What we know is that the majority of schools in the U.S. have some sort of school wellness program. After all, it was mandated. But the implementation aspects is not being practiced consistently. And that is consistent, too, with the literature by, or the research conducted by several people throughout the country. All right, so here we go. It's like the so what, and this is something that I like to talk to my students about. We found all of this, but what does it really mean? Well, we like to think that our contribution to the body of knowledge is unique because while we have, or others have looked at rural populations and others have looked at minority populations, we have yet to find someone who's looked at this at a rural and minority catchment area, and that's what's unique about our particular study. But what does this mean in terms of translation to practice? What it means is that we do need to promote the use of health policy among school staff, including teachers, and that some of the recommendations provided were that the policy training be included during teacher-staff orientation, and that administrators encourage review of these policies during the hiring process and also during performance reviews. And these are recommendations that came from school personnel. They also suggested to have some sort of a highly visible basic conceptual framework that is easily seen throughout the school as a reminder, as a cue to action for everyone in the school, and to have the more detailed information in a highly accessible area for them, such as the teacher's lounge. And finally, they suggest that we somehow determine to find ways to work against barriers. So the barriers that the schools encounter, even within our 7 schools, seem to be very context-specific. Even though they were all in rural minority areas, some of the barriers were unique to a particular school. And so they recommend that we utilize the teachers and the staff within each school to identify what those barriers are, and more importantly, identify those that are modifiable, so that we don't waste our time trying to change the unchangeable. And this one came from our administrators, which is resolve the view of parents among teachers. We may want to remind parents or teachers somehow that they serve a dual role, and sometimes in their teacher roles they forget about what limitations they have as parents. And so reminding them that we're all on the same team would probably be helpful in terms of implementation of these programs. So in conclusion, again, this presentation is based on a manuscript that was submitted, and we did modify the title just a tad. And of course, the funding was made possible through NIMHD. It's no longer a center, it's now an institute. I'd like to thank you and open it up for questions.
Okay, thank you very much, Masako. So I think we have time for one question, and the question is, other school-based interventions have certainly encountered barriers around time and competing commitments. Did you come across this kind of acknowledgement as well? And how would you propose that your respondents would hope to address that?
Yes, we did encounter those. And what we find has worked for us most is tying in the benefits of these programs to academic achievements, because at the end that's what they actually care about. That's the metric they're being used to measure their own performance. That's what they're being held to. So we can tout the benefits of health and wellness and the school wellness policies all we want, but at the end of the day, the ISDs, the superintendents, in fact, the state boards want to know how does this affect student academic achievement. So that's our tie-in.
Thank you very much, Dr. McHire. We will have time at the very end for questions for any of the panelists, so okay. Hopefully we'll be able to fit in a couple more questions at that point.
Great,
so I'm going to quickly move on to introduce 2 presenters that will be working together for the next presentation. It's Dr. Sally Davis and Dr. Sarah Sanders, or excuse me, Ms. Sarah Sanders. So Dr. Davis is a tenured professor and chief of the Division of Prevention and Population Sciences in the Department of Pediatrics at the University of New Mexico School of Medicine and the Health Sciences Center there. She has more than 35 years of experience conducting school-based interventions, particularly with the American Indian and Hispanic populations. Ms. Sanders is a master's level exercise scientist, dance educator, and registered nurse with 17 years of experience in healthcare and research, and she is the exercise scientist for the Chile project, Chile standing for Child Health Initiative for Lifelong Eating and Exercise. Dr. Davis and Ms. Sanders, please take it over.
Thank you. Okay, you should be able to see the screen now and the slides. So thank you for that introduction, and I'm pleased to share with you a little bit about the Chile project, which, as you heard, stands for Child Health Initiative for Lifelong Eating and Exercise. Sorry. It's a multi-level trans-community intervention to decrease obesity risk in 3 to 5-year-old rural Hispanic and American Indian children. We worked with 16 Head Starts. There were 8 intervention sites and 8 delayed intervention sites, and we had more than 3,600 children enrolled during the time of the study. The primary goal was to design and implement a trans-community obesity prevention intervention for promoting healthful behaviors in preschool-aged children and for instituting preschool environmental changes to reduce the children's risk of obesity. And this is extremely significant because, as everyone I'm sure on this call knows, that the prevalence of overweight has increased, and obesity in childhood is a risk factor for obesity and chronic disease in adults, and obesity is now costing $117 billion, that's with a B, dollars annually, and there are many social and psychological costs. The rationale for using Head Start, I'll just say that prior to this we did a study, an 8-year multi-site study with American Indian children called Pathways, and we worked with 3rd, 4th, and 5th graders. It's almost too late by 3rd, 4th, and 5th grade, so we really wanted to focus on early, and so it's essential to start early. This is where the enrolled children spend their days. There are over 900,000 children enrolled in Head Start across the country. 90% of those, by regulation, come from low-income households, and health and nutrition are a focus of the Head Start program, and family involvement is a priority. So the conceptual framework is a socio-ecological model, multi-level trans-community, and it addresses environmental determinants of healthful eating, physical activity, and television viewing, and other screen time, I might add, and individual and interpersonal strategies to influence behavioral determinants. And you're going to hear a little bit more about how we actually addressed all of the constructs on this conceptual framework. And whoops, I'm sorry, we somehow went backward.
Keep going.
Well,
yeah,
I'm almost. Okay, the aims to increase moderate to vigorous physical activity, to decrease television viewing and screen time, to increase consumption of fruits and vegetables and whole grains, to decrease consumption of sweetened beverages and high-fat foods. And the intervention has 6 components: a classroom curriculum, in-service training for the Head Start teachers and aides, training for Head Start food service providers, for healthcare providers, they were included as well, a family component, and a grocery store component. And Sarah's now going to tell you a little bit about each one of these 6 components.
Go to the next. So the first component was the classroom curriculum, and each component was based on evidence for what works to maintain a healthy weight. So the first one was the classroom curriculum, where we focused on nutrition and physical activity, and research has shown that about 8 to 12 exposures to a new food is what it takes for young children to start to develop a taste for that food. So the curriculum helped the kids have exposure to fruits and vegetables 4 times in the classroom through recipes and experiences with whole fruits and how they look when they're cut up and used in recipes. The additional exposures came from the food service component, which we'll talk about in a moment, and also the family component. Then the physical activity part of the curriculum included a notebook of physical activities that were divided into something we call game time, which was structured activities for the children, move and groove, which was short dance and song-like activities, and exercise breaks, which was a box of cards that the teachers could just pull out an activity at any time during the day to get the kids involved in physical activity. These lessons were meant to add 30 minutes of structured physical activity to the school day on top of what they were already doing. So most programs already had a structured amount of recess time or outside time or other physical activity, but many programs couldn't tell us exactly how much time they were doing, so we said let's add 30 minutes a day on top of that. And that's based on the evidence that says that preschoolers need at least 2 hours a day of physical activity, 1 hour and up to several of unstructured physical activity, and 1 hour of structured physical activity. And then the in-service trainings for Head Start teachers and aides included hands-on work. We did physical activities with them that we wanted them to do in the classroom so that they would be confident in doing those activities. And we also worked with them on the nutrition activities and lessons so that they would be confident creating those lessons with the children. And those happened about 4 times a year. There were 4 modules each year for the nutrition lessons, where they did a fruit for 4 lessons and a vegetable for 4 lessons. And then the next module they went on to a new fruit and vegetable. So we went out at the beginning of each module, and the curriculum actually lasted 2 years so that the kids would have a new fruit and vegetable about every 4 or 5 weeks during the school year across 2 years, since the kids stay in Head Start for 2 years. For the food service, their training was focused on incorporating the more fruits and vegetables, whole grain foods, low-fat foods into the Head Start menus, and also working with them to include the target fruit and vegetable of what the kids were working with in the classroom with the teachers in the meals and snacks, so that during the time, say, that they were working with bell peppers, the cooks would put the bell pepper into the salad or into other menu items, and the kids might recognize it, or the teachers might draw attention and say, look, this is bell pepper. We worked with this the other day in our classroom, remember? And the kids might be more familiar and more willing to eat it in the actual meal and snack. And those in-services for the food service staff were coordinated with the teacher in-services. The healthcare provider was a unique component of the Chile project. We met with the healthcare providers, each one in the local community that served that community where the Head Start we were working in, and focused on providing them preventing obesity guidelines for young children, and invited them to the family events so that they could participate in sharing the messages with the family of the Chile curriculum. The family component was comprised of take-home materials. So each week that the kids did the lessons in the classrooms, the teachers sent home materials that we had created that included recipes and activities for the caregivers and families to participate in with their children. And then we also held family events 2 to 4 times a year where we invited the families and worked on adult-level Chile messages of healthful eating and increasing physical activity. And finally, we had a grocery store component, which is another unique aspect of our study. And so as you can see across all of these components, we're reaching at different levels to address preventing obesity. In the grocery store, we put up labels that had our Chile logo so that if the children went shopping with the families, they could identify that and say, we're working on this in Head Start, and might encourage their parents to buy more fruit and vegetables. And we also labeled whole grain foods and low-fat dairy in the grocery stores. In addition, we provided recipes that coordinated with the classroom lessons. So there was where we got the 4 other exposures for a total of 12 exposures to a particular fruit or vegetable to give the kids a chance to become familiar with that fruit or vegetable.
Okay, I'm going to close this with lessons learned. So these are just a few of the lessons learned, but that the seasonality of fruits and vegetables and availability was really, we couldn't always include fresh fruits and vegetables, so we included frozen or canned that were lower sodium or in water instead of, or light syrup instead of syrup. To include both the teachers and the food service staff in one training when possible was really important, so that they were supporting each other and on the same message. To bolster the family participation with invitations, posters, and performances. Very challenging to get families who have been both or all of the members of the family working, and then to get them to come to an evening event. We also tried to schedule them around the time when families could come. The healthcare providers have very little community time, and so we tried to build it around when they could come to be involved, and also things that they could do from their office. And the grocery store is really focused on business, and so when you ask the grocery store to carry whole grain pasta, and if there's not a demand for that, it goes rancid really quickly, and so we had to work with them and create the demand at the same time we were creating the supply. And so the last slide, I'm going to go to a very short YouTube video so you can actually see this project in action. But on this slide, the curriculum is available through a website, and the article that's in the Journal of School Health is cited here. So this should not take very long here.
It's on pause. Go ahead and hit play.
Okay.
Yeah, I think you have to hit play, and then it should
Yeah,
work.
we're working on it.
What are these drugs called? The Chile Project is a child health initiative for lifelong eating and exercise.
What do you see when you look through your magnifying glass?
And it's a multi-community study in 16 Head Starts all across the state of New Mexico.
Well, we know that by the time they're 8 or 9 or 10 years old, they're still formed, and it's much harder to check their behavior. And so the idea is the younger, especially in reducing food habits.
The team is really a resource for the Head Starts in the community, because we're providing a lot of things that either they need to provide or provide or want to provide.
The teachers an opportunity to do activities with children that really promote and helps them try out new foods, do it otherwise.
It's a cucumbers grow. In the garden.
And then the nutrition, eating the bottle, enjoying it, they were energetic, and they were willing to, try anything, even though they were that young.
They're going to be analyzing to see whether Head Start or teacher leaders have any different outcome with the young on the Head Start to regular good Head Start work. The ultimate goal is to reduce the children's likelihood of developing diabetes. there is a grocery store component where we actually label foods that are recommended by the Chile Project.
Yeah, look, the sugar is only 1, so it's good, huh?
If you went to a grocery store and you say you're going to get whole bread, there's like abundance of different types of what is considered maybe whole wheat or somewhat whole wheat. And so by having that label, it really defines what exactly is nutritious and what exactly whole food 100%. Well, being in the community where I think it's very prevalent, I was right down to what we were doing for nutrition.
Okay, let's see. Enter get one level.
And obesity starts very young in life, and for late in elementary school or mid-school or high school, it's really much, much harder to do. And then, of course, if we wait until we're adults, it's almost impossible to change this.
Okay, that's it for the Chile video. Thank you for listening to our presentation.
Thank you, Dr. Davis and Sanders. I think we do have time, again, just for 1 or 2 questions. So one question is, just seeing the video, we were wondering if you had to do some changes in pricing, because some previous work has shown that even if foods are available and equally priced, there isn't always uptake at the grocery store level.
We didn't focus on changing the cost, and as we said, that most of these were small mom and pop type grocery stores. The foods were just the price that they would have charged anyway. We did consider having a lower price, but we were creating the demand by through the family nights and the take-home materials, and having the new items that they added be reinforced in the classroom, and so they match. So if we were talking about whole grains, that's the week that they promoted whole grains, and we had recipes and labels and a lot of promotional. I think it would be hard for us to ask the mom and pop grocery stores to lower their price and then later maybe increase their price, just because their margin of profit is very small anyway.
Right. Okay. One last question. So why did you choose the socio-ecological model, and what did it add to your intervention?
Well, it added to take it not only the focus on the children and the children in the classroom, but to add the family and the community, and as you saw, the grocery store and the whole environment, because previous research, the evidence shows that you really have to address it from more than one way, that you can't just address it from the individual. And with children that young, they are generally not preparing or doing the shopping, or don't have that much control over what they eat. Also, by including the food service, they're changing what they're eating at school as well. So we just felt like that the socio-ecological model fits these types of interventions much better than, say, targeting just the individual to change their behavior. As I think others have said, it's almost healthy by default, so that you're creating an environment where it's a little bit easier to be healthy.
Right. Yeah, very good point. Okay, well, thank you very much. We will be moving on to Dr. Belansky. Okay, Elaine Belansky is a social psychologist and assistant professor at the Colorado School of Public Health and associate director of the Rocky Mountain Prevention Research Center. Currently, she's working with rural low-income schools in southeastern Colorado to implement school-based environment and policy changes that increase opportunities for healthy eating, physical activity, and mental health, and decrease high-risk health behaviors. Dr. Belansky, thank you.
Thank you so much. I think we're going to start by doing a quick poll. And so while that's happening, I'll just go ahead and thank Asha and the United Health Foundation for inviting me to be here. I'm going to spend the next 15 minutes telling you about AIM, a strategic planning process we've developed and used with elementary schools in rural, low-income Colorado. So make sure you answer your question here. And I'm not sure what's going to happen when I go to my PowerPoint with the poll, but if the poll doesn't happen, it's not going to be the end of the world.
Okay, we can read the poll to you because I think you can't see it.
Okay. Just let me know when you get your answer. My real question is how many people said that if their boss told them that they needed to start a wellness initiative, they'd immediately start hoarding chocolate and chips and making a stash in their desk.
Okay, so the answers are, wait 1 second, it's still in progress.
Okay.
Okay, now it's closed, I think, right? So 0% admitted to stashing chocolate chips and pop, let's put it that way.
Okay.
79% said happily agree, and you enjoy strategic planning. 14% thought not another strategic plan, and 7% said tell your boss thanks, but no thanks.
Okay, well, thanks everybody. It's really important to check in with people about how they feel about strategic planning because you know, some people have really had it with having to undergo those kinds of processes. So getting a feel for who you're working with is very helpful. Okay. So what I'm going to do now is tell you about intervention mapping and adapted intervention mapping, and I'm going to walk you through the process. And I want to start by sharing with you this roadmap. So as I was saying, AIM is a strategic planning process and it stands for Adapted Intervention Mapping. It was born out of a very comprehensive planning process developed by the University of Texas and others, and they called it intervention mapping. And what I've done is taken intervention mapping and adapted it to be more community friendly and something that we universities can do in partnership with schools to help facilitate change. So when we're working with schools, we actually refer to AIM as assess, investigate, and make it happen. And as you can see here, it's an 11-meeting process. And the purpose is to increase student opportunities for physical activity and healthy eating during the school day. AIM has been tested in 27 elementary schools, and each time we find that schools put an average of 4 evidence-based environment or policy features into place. The next several slides show you some examples of environment and policy changes that have been put into place as a result of AIM. This is my favorite one. It's a half-size basketball court that was put into place to address something that the school learned doing its needs assessment, which was that 4th grade boys in particular were having a hard time finding ways to stay active during recess. It's very common for schools to initiate some sort of playground campaign that's a combination of improving the environment by making playground markings like these, but also making equipment available during recess. Simple, low-cost changes like this really can make a difference with physical activity. We've had a few more ambitious schools actually design and redesign playgrounds to maximize physical activity. This is a beautiful example of a brand new playground in Crestone, Colorado. We also have clever uses of classroom space. Here is a new piece of furniture that's both a chair to be used in the classroom, but it's a storage bin with lots of equipment for the class to easily get out for recess each day. AIM also focuses on healthy eating, and a few of our schools have been able to make some really nice improvements to the way their lunchrooms work by adding more fruits and vegetables to the line and reducing desserts. So here are some before and after photos. And one of our more recent schools put in new water fountains around the building, which was really important because these kids weren't able to get drinking water. They had some water fountains, but the bubbles, the water wasn't coming out very well, and it wasn't cold, and so kids were using caloric drinks instead. And so they've got some really nice new water fountains and some beautiful thank you notes that the kids made for the janitors who worked so hard to get the water fountains in place. Some of our schools have put policies into place around foods that can be brought in for birthday parties and other classroom celebrations, fundraisers, etc. So here's an example of something that one of our schools put together and shared with their community. I know I'm going very fast through these slides, but they're all going to be available. So now I'm going to quickly run through the flow of the AIM process, and more details can be found in the paper that is going to be available to everybody, whether you're an ASHA member or not. So the first thing we do is we hire and train facilitators to work with schools on the AIM process. We train these people in the 11 meeting process, on the latest best practices for increasing physical activity and healthy eating, on key elements of intervention mapping, and on group facilitation skills. And then the facilitator goes to the school and starts the process of putting together a group of people who are willing to go through the AIM process. And principal participation is the first step, because research shows us that wellness changes are very difficult to make without principal involvement. And we've actually gotten to the point where we won't work with a school unless the principal is willing to come to the 11 meetings. Once the principal's on board, he or she helps us put together a task force of at least 7 people, and you can see the types of people listed here. It's really important to get the food service, physical educator, and classroom teacher on that task force, because they end up oftentimes implementing the changes that the task force wants to make. So having their participation at the get-go really pays off. Once that task force is put together, we work on accomplishing a needs and assets assessment. And so what you see here on this slide, I'm not sure if you can see my cursor or not, but on the left side of the slide, we have a survey called the School Environment and Policy Survey, which you can find online at our website. And it's a way for us to find out which best practices a school has in place. Once we get schools to complete this survey, we translate it into this document. We have, this page happens to show you what it looks like for healthy eating, but we have a similar page for physical activity. And we show the school in a color-coded way which best practices they have in place. So if it's green, it means they've got the practice in place. If it's yellow, it means it's partially in place, so there's still some room for improvement. If it's red, it means it's not in place at all, and if it's black, it may not apply to that school. So the goal is to turn this sheet to have all green over time. Once they have figured out their, once they've figured out their strengths and need areas for improvement, what we do is we focus on very specific daily outcomes of healthy eating and physical activity. So if you look at the bottom one, for example, it talks about 60 minutes of physical activity during the school day. And the reason why we aim so high with 60 is because we know from research that if we're lucky, they'll be active 50% of that time. So they'll be actually getting 30 minutes of physical activity during the school day. We also have very specific outcomes for fruit and vegetable intake in particular. Once the task force understands what the goal is, that they're trying to get that 60-minute target of physical activity and they're trying to get a certain amount of fruits and vegetables in per day, what they do is they look at a menu of best practices. So this is, we've got one menu for healthy eating and one menu for physical activity, and this is based on research where we've looked at journal articles to find out what's already been determined to relate to increased physical activity and healthy eating. So we show them these best practices and encourage them to try to put some of these into place. And the way we do that is we facilitate them through an importance by feasibility exercise where they brainstorm a list of changes they might make to their school, and we have them rate each of the changes for how important they are and how feasible it is that they could get those changes put into place. The definitions of importance and feasibility are over on this side, on the left side of the slide. And due to time, I'm just going to keep going, but it's there for you, and it's also online. Once schools have chosen what changes to make, and typically they choose 2 physical activity and 2 healthy eating changes to make, they develop an action plan. So this principal is leading his task force through the action planning. He's got different color-coded stickies on the wall. They each represent a different change that the school wants to make, and he plots it across months and seasons. And that helps the task force get a sense of whether they've got too much on their plate or whether this is a feasible action plan. Part of the action plan, and this is an element of intervention mapping, is to address personal and external factors to get changes put into place. So that's kind of complicated language, but what this really means is that if you want to get your food service person to provide healthy snacks for children after school, for example, which is what this little cartoon shows, you kind of need to take into account what is it that they need inside of themselves psychologically, and what do they need from their immediate environment. And once you get a handle on that, you can make sure your action plan addresses that. So for example, in the lower right-hand corner, you see that there's somebody offering some social support. I'll shop for fruit for you. And on the left side, you see 3 kids at a table giving the food service director or food service person some positive reinforcement. We like fruit kebabs. And then inside of the food service person's head, she needs to have certain attitudes and beliefs about her ability to really pull off yet another thing added to her plate. So the purpose of this is to make sure that we're really planning for success. Next up, we engage the task force in evaluation, and this can happen in several different ways. Sometimes a task force might want to get a read on their school community for a change they may want to launch. And this is an example of that, where this task force was considering having a breakfast after the bell, which is a best practice, but they really wanted to make sure they knew if their community was behind them and supportive. And so before implementing the change, they conducted this survey. And found out that it was sort of a 50-50 split. And so they decided that what they do is first really work at gathering more support and explaining the benefits of this in staff meetings before actually implementing the change. So that's an example of using evaluation to gauge community support, but the same exact survey could then be used after it's been implemented to see if the school has succeeded in getting more support for an initiative. And then finally, in the AIM process, we work very hard to sustain the initiatives that the school has put into place. And we've got a couple of strategies for doing this. One is we try to help schools get things in writing. Sometimes it's school board policy, but more often it's a policy that the principal puts into a family handbook and a teacher handbook. It's a little bit easier to do that than to get a board-approved policy. So we spend time really trying to get things in writing so that all that hard effort, keeps paying off year after year. And also, what we've been doing is running some training sessions with task forces so that we can teach them how to do AIM on their own once our external facilitator has finished the work with them. So I'd like to start that final poll now, if possible, or really soon, while I summarize what I think is happening with AIM and why I think it's working pretty consistently. I think what's happening here is that we've got, a trusting community-university partnership. And once we've got that in place, we do a strategic planning process together that has some very key elements: external facilitation, needs assessment, some of the things that I talked about, specific goals and a menu of best practices. And with that, we're able to get best practices implemented in schools. Are we able to do that poll question? Well, while we're figuring that out, I'll tell you about the next steps for our project. One of the things we're thinking about doing is offering a AIM facilitator training and certification process so that we can take this strategic planning beyond Colorado. We're also going to investigate if AIM can be used well in middle school settings. And then another thing we're going to try to do is work with local public health departments to deliver AIM to schools in their area. And I'd love to hear if you all have other ideas of things we might do. I'm not sure what's happening with the poll, so I'm going to just quickly show you this acknowledgement page and let you know that our funders are the CDC and the Colorado Health Foundation, and also to let you know that if you go to our website listed here and you click on the AIM graphic, you will see a lot of the materials that I showed you today.
The audience cannot see your acknowledgement page because they see the poll.
Oh, okay.
So we can give you the results. Yeah, we'll give you the results. So far, it looks like 42% say no money, 21% would likely cover travel expense, 16% say would likely cover travel and training fee, and 21% not applicable.
Thank you so much. I'd love to see those numbers. It's really helpful to get a sense of if we were to do a training and certification process, you know, how much money would we need to raise from a funder to get that done. So just finally, just want to let you know that if, hopefully you can see this page, if you go to our website and you liked any of the things I showed you, you can just click on this AIM graphic and it'll bring you to most of the things that I showed you today. Thank you so much.
Thank you, Dr. Belansky. So we have time for a question or two, and I have a question. So in your sort of work with these schools, what was your hunch that by having fairly stringent requirements of principal involvement, et cetera, at the beginning, were you getting schools that were really ready to change, or were you somehow moving them along that sort of behavior change model?
That's a really good question. I think it was the latter, because the schools that we've been working with, while, you know, wellness is definitely, you know, something they value, they have so many other priorities that they're being held accountable for. And so they honestly seem somewhat extrinsically motivated to work with us, and by that I mean we pay them from our grant $3,000 to partner with us on the AIM project. And I think that financial incentive is what really gets them to work with us. So I don't think we're working with schools that are already really interested and early adopters.
That's very helpful. Thank you. There's one additional question from the audience. So how is this approach, especially the AIM task force, different than using wellness policies in school and district wellness teams, which are already required?
That's a great question. I have a couple of thoughts on that. First is that in many cases we are working with a wellness team that was convened in order to be in compliance with the local wellness policy. The difference is that wellness policy teams are typically district level, so they're not in the school building, and AIM is happening in the school building. Another difference I would share is that typically, if you look at local wellness policies, they're very general with sort of, you know, weakly worded language so that the school can live up to the policy, basically. And with AIM, we're very specific about making very precise changes. So I just would say that's another difference, just that level of specificity of the changes that a school building will actually make. I think without the pressure of it being a district level policy.
Just one additional question. So did you find that the sort of strategic planning kind of employer model aligned with the strategic planning initiative that for the employees of the school otherwise, or were they kind of two separate things?
I'm not sure I'm following that question.
I said it very poorly. It seemed like at the beginning, and certainly with the poll of this presentation, that there was an idea that this was strategic planning as might occur in lots of workplaces. And so I was just wondering how strategic planning around obesity initiatives that are really to impact the children, the students, really fit in with strategic planning that might have been going on for employees of the school.
Oh, I see. In our case, you know, I mentioned that we've been working with 27 schools, and very few of them had any kind of staff wellness initiative happening. A couple of them had received grants from local groups here in Colorado to do a few little staff wellness things like walking groups or Zumba after school, but they hadn't engaged in a strategic planning process. So my sense is that this is the first time these schools have participated in a strategic planning process around wellness.
Okay, thank you so much. We do have an additional question that we'll try to make time for at the very end so we can get to the next presentation. Thank you very much, Dr. Belansky. Really interesting. Okay, so we're going to move on to, again, two presenters that we're fortunate to have, Deb Johnson-Shelton as well as Geraldine Marino. So Dr. Deb Johnson-Shelton has a PhD in special education and has been involved in designing and evaluating programs in schools and community health systems to support youth and family development for over 20 years. She's also currently an associate research scientist at Oregon Research Institute and the principal investigator of a study, Communities and Schools Together for Child Obesity Prevention, or CAST. Dr. Geraldine Marino is currently a professor in the anthropology department at the University of Oregon and a senior research associate at the Oregon Research Institute. Her research is located at the intersection of nutritional anthropology, human biology, and medical anthropology. So thank you very much, and I'll let you take it from here.
Great. Thank you very much. I'm Dr. Deb Johnson-Shelton, and we're really grateful for this opportunity and privilege to talk with you today. I'll be sharing with Geraldine Marino-Black the results of our study that is published in this month's issue of Journal of School Health on the prevalence and prediction of overweight and obesity among elementary school children. This study was actually conducted as part of our 5-year community-based participatory research study called Communities and Schools Together for Child Obesity Prevention, or CAST, as you said in your introduction. And this is one strand of our research that we've conducted over the last 5 years.
Hello, I'm Geraldine. Are you seeing the PowerPoint now?
Now we are. Thank you.
Okay, great. Thank you also for the opportunity to share the results of our research. As we've said before, and you've heard before, and most of you who are participating in this webinar know, obesity among children has tripled over the past 30 years. And there are important differences and disparities in the prevalence of child overweight and obesity, and we find this both within states and between states. We also find some of these disparities to be associated with SES, school outcomes, and neighborhood environments in which the children live.
For our study, we began our study with a real investment in the idea that BMI measurements in schools is important for a variety of reasons. First, for helping to educate parents and children about the health risks of obesity, which often we can take for granted that people know and understand and see the relevance of these health issues for their own children or families. Our experience is that you can't always just take that at face value. It's also important for identifying the groups of children who may be actually more vulnerable to overweight and obesity within a school or within a community. And finally, it's really, this is an important approach for helping to inform schools and districts on where they might point scarce resources for ameliorating obesity risk among their children.
So we would like to, while we're looking, or before we look at this slide, just do a little poll question. And we want to ask you to answer the question for us: does your state mandate or recommend BMI or body composition measurements by school?
Okay. It is up now. So the poll is in progress. We'll just take a minute to let a few more people answer.
Great.
So far it looks like about 50% are saying no, or a little under that, and the rest are divided among the yes and not sure.
Okay, so those results are pretty much what we would expect, because as you can see in our slide here, there are two types of, well, I want to just backtrack a little bit. There are two types of school-based BMI measurement, and one of them is BMI surveillance, and this is the one that we primarily talk about when we're talking about looking at how, just getting a general picture of what's going on in the school district or in the community. The second is screening, and there actually can happen at the same time, obviously, but it is the one that screening would allow for actually identifying at-risk students, and a school would have a very different approach if they're implementing surveillance only or if they're implementing both surveillance and screening, and they may just be implementing screening. A study, and as I said, your results that from the poll are pretty consistent what is in the literature. A recent study found that less than half of the states required or recommended BMI or body composition screening in schools. And this was from a study by Lynchy and Masden in 2011. So if the group is saying a little bit more than 50%, that's a movement in a positive direction in terms of thinking about the changes that are happening. Lynchy and Masden also found that if a state did have a mandate, they were also a state that probably had a higher adolescent obesity prevalence. Our study is actually with elementary school students, but that's what their population was.
So we really had three goals in this study, looking at BMI measurement in our schools. First, we wanted to establish baseline values in order to examine student risk for obesity within our 5-year project. Secondly, we wanted to evaluate the level of influence of multiple student levels of predictors on child risk for obesity to start to understand what were the factors involved in predicting which children would be obese or not. And finally, we wanted to examine the patterns of variation in overweight obesity among the 7 elementary schools within our project school district. This study was actually conducted in Oregon. This is one of the states that doesn't require or recommend BMI or body mass measurement in the schools. And prior to our study, we struggled with a real lack of available, reliable local information or even statewide information on child obesity patterns. And for instance, one study in 2010 that we looked at conducted parent telephone surveys, and the finding was that 9.6% of elementary students were in the obese range. Another study done by the Child Obesity Action Network, again using parent report, found that among Oregon youth about, I think about 26, a little over 26%, or about a quarter of the kids were in the obese, overweight range. But a third study that actually Dr. Marino strongly supported earlier in the 2005-06 years found that 35% of our county children, where our project is actually located, were in the overweight or obese range. So the range of findings around where the children are falling in terms of their range of risk here was really variable, and using a lot of measures, parent reports, that weren't as reliable as objective measures by going and actually conducting the weighing and measuring on an annual basis. Oregon, on the other hand, does have a lot of state policies and legislation that are aimed at reducing child obesity risk. We've done a really strong job of eliminating or limiting competitive foods that are sold in public schools. We are also a very strong supporter and funder at the state level for farm to school in our nutrition programs in K-12 education. And we have new legislation that is to come into effect in the year 2017 that's going to require 150 minutes per week of PE in elementary schools and 225 in middle schools. So, we've come a long way in a lot of these other areas. In terms of our study procedures, we recruited a little over 2,300 elementary students and used data from the school records for our predictor variables in our study. We also used trained research assistants through our project that we're here at Oregon Research Institute. We did rely heavily on a school community coordinator. As part of our grant, we shared a position with the school district who had access to confidential records, and this is an important component of being able to share data back and forth between our research institute and the school district.
In order to analyze the data, we used the CDC EpiInfo analysis tool, and the particular part of that is called NewStat. It's a nutrition anthropometry program that calculates BMI from age and gender norm tables. And we calculated the variables that we used were the raw BMI, the Z-score, and the percentile equivalent. We also chose in this analysis, and I want to remind everybody that this is our baseline from our year one of a 5-year longitudinal study, and we continue to do the measurements throughout the 5 years. What we're reporting on now is just from year one. At that point, and we continue to believe it's important, we categorize the students into 2 groups, and this is using O'Malley. And the first group is all the children who are less than the 85th percentile. And the second group is all the students who are greater than or equal to the 85th percentile. And we chose to do this because we didn't want to miss any of the children who could possibly be at risk for health implications related to being overweight or obese. In the actual analysis, we used a generalized mixed modeling approach with nesting in schools and a 6-variable model as is described in the paper. Our sample was comprised of 93% of the district's enrollment. And when we did a comparison to the whole district for that year, and this again is just the elementary students and our sample, we were very similar on ethnicity and gender. However, we did have a lower number of children listed as eligible or free for reduced lunch in the school. And we were using this particular variable as a proxy for SEF. So it's very possible that our BMI results may actually be underreporting the actual level of overweight, obesity, in risk in the district.
So this table here begins to show at least the demographics of the sample in our study. I know this is a lot to digest, so you have the paper, and then again, all these presentations will be available to everyone. But this table shows that the average age of the students in the study, as expected, would be about around 8, so 2nd, 3rd grade, and pretty evenly split between male and female. 55%, we looked at actually sibling relationships, and Geraldine will share that was some interesting finding in our study. But so we looked at sibling characteristics, that is students that had siblings in elementary school, and a little over half had no siblings. 46% were also eligible for the district's free and reduced lunch, which was our proxy for SES or low SES. And then we also looked at English as second language schools. There were 3 of them in the school district, and 44% of our sample were in attending those schools. The percentage of students in each grade was pretty consistent across all of them, ranging from 16 to 18%. So here we found that the combined proportion of district students who were overweight or obese was 36.7%. Of these, a little over 19%, 19.4% were in the obese range. One of the things that's sort of interesting when you look at that overweight or obese range, you're seeing actually a lot of children are not in the overweight, they're actually in the obese range in those 2 combinations across different schools. Also, there was really quite a large variation across school, a range of between 32.6% to 45.5% of the students in the school were in the equal to or greater than 85%, or that overweight obese range. So while that wasn't significant, it was in the direction of significance. And at a school level in our study, that was an important piece of information in terms of where to set some priorities for programs.
As you can see here, the 4 of our 6 predictors in the model were significant. The strongest predictor was ethnicity, as is commonly found in other studies, with Hispanic students being almost 2 times as likely to be in the overweight obese category. The 5th grade students also were about 1.74 times more likely to be in the overweight obese category when compared to children in kindergarten. Students who were eligible for free and reduced lunch were 1.2 times as likely to be overweight or obese. And interestingly, students with siblings were found to be less likely to be obese when compared to students who didn't have siblings.
Okay, we need to wrap up.
Okay, so just very quickly then, the results of the study indicate that it is currently important to look at the prevalence rates in school districts and to do this within a particular district over a period of time. Prevalence can vary. In our study, the variation was primarily within individual variables and was accounted for, as we said, by ethnicity, SES, and grade. And it's also important to recognize that in this district, when we had 3 schools who offered the ESL program, which would have put a variation in terms of the distribution of the Hispanic ethnic group. Despite this, the school attendance was not a predictor of overweight obesity, which would indicate that it's probably best to look across schools and not try to target specific schools.
So just really in conclusion, we found that the collection of school-based BMI surveillance or screening data is very important to the effort to reduce or prevent child obesity. We still know very little about the distribution of these risks across schools, even within a district, and such information is really important for formulating these district-based health policies and health initiatives. So with that, short on time, we just want to say thank you, and these are 2 of the lovely reasons why we're involved in this kind of work. So
thank you very much. So just one quick question. Why do you think that they're higher in your study compared to state levels?
Well, we think that they're higher because the state levels don't exist. We don't really know what's going on in the state, so we can't really say they're higher. They're fairly consistent. If you look at the research that was done in 2005, the data is consistent, and that was throughout the whole county. And then they're close to the second study that was indicated. So and they're close in terms of national levels as well. I think the one study that had the very low percent was a very small sample. It was a telephone sample, and it was, again, parent information. So
Gotcha.
I think it behooves to really do this kind of work and keep the surveillance, if not the actual monitoring going on.
It's also really interesting considering what seems to be national data indicating a plateauing of obesity prevalence. Well,
right, and I think...
Yeah. Go ahead. Go
ahead,
sorry.
Say that plateauing may be temporary, and it probably there's differences in different places as well.
Absolutely. Okay, well, thank you to all our presenters. We do have a few additional questions that for the presenters as a group. Hold on one second. I'm just going to gather them. So one question for Dr. Johnson and Marino. How useful do you think BMI is when providing recommendations on obesity and overweight in adolescent populations?
Well, I think it's really useful in a lot of ways in adolescence. I mean, in some ways it's really difficult working with children at an elementary school level because communicating these health issues is difficult. I think in adolescence it's actually probably going to be even more important to have really astute and helpful health educators helping the youth understand what kind of behaviors really feed into this, and to make it more about their general life development and to be part of a broader educational kind of opportunity for them about their development and health and how this relates to everything in life. So I think it's very relevant for middle school and beyond, and even into high school. And we actually regret in many ways we couldn't have followed our children into middle school and high school.
Also, a recent study by Hughes showed that the trajectory does level off a little bit in middle school, that there is the increase that we see, the upward trend of prevalence in elementary school, and then in the older children, it does tend to drop off, and that's post-puberty most likely affecting that. So it may actually be very important to be able to identify those children that don't decrease in adolescence and stay either, especially if they're staying in the obese category. So I think that would be an important factor.
So thank you to all of our presenters. I think today we've heard about reasons to start early, reasons to work with children into adolescence, reasons to work with school personnel, and different approaches for all of the above. Do any of the presenters, particularly the earlier presenters, have any last-minute comments they'd like to make to the group?
No.
Okay, we will be able to end on time then. Again, thanks to the audience for the poll participation, which is always fun, and to our really esteemed and wonderful presenters today.
Thank you again for the opportunity to present.
Yes, thank you very much.
Thank you.